Okay, so today we're really diving deep into the Delphi method and how it's being used in medical education
Yeah,
research.
it's a really cool method.
Yeah, and you've brought some fascinating articles from academic medicine that all use this Delphi approach.
Yeah,
And they're tackling some pretty big questions like, what skills do residents absolutely need when they're transitioning to practice?
right.
What about AI competencies?
Huge topic.
Huge, right? How
There's,
do we even begin to teach that stuff?
yeah.
What makes a clinician educator a good teacher? And then even geriatrics care, like what are those core
Hmm.
competencies? So we've got this great set of articles, and what I'm hoping we can do today is sort of pull out those threads.
Yeah.
What are the common patterns we're seeing across these studies? Are there any interesting twists that each one takes? And then I think really importantly for anyone listening who's maybe thinking about doing a Delphi study themselves,
Right.
what should they be keeping in mind?
Exactly.
Especially if they're thinking about trying to publish in a journal like Academic Medicine.
Yeah, so we're going to be looking at not just what they found, but how they got there using the Delphi technique.
Yeah.
And I think by comparing these different applications, we'll get a really good sense of what makes for a solid Delphi study,
Yeah.
a robust one that's likely to get published.
Okay, so let's jump in.
Let's do it.
One of the things that really jumps out when you look across these papers is this consistent use of multiple rounds of surveys,
Yeah.
all with the same group of experts.
Right.
So you're going back and forth, and it seems like that back and forth is really fundamental to how the Delphi method works.
It is that iterative process is really at the heart of the Delphi method.
Yeah.
And it allows the experts to kind of refine their opinions,
Right.
to see what everyone else is saying, and then kind of go back and reconsider their own views in light of that collective feedback.
Yeah.
So for instance, Rastucci and colleagues who are looking at the transition to residency skills,
Yeah.
they went through 3 rounds of questionnaires with their expert and stakeholder panels. And then Lee et al., who were tackling those AI competencies,
Yeah.
they used 2 rounds for their initial survey
Okay.
and then did a separate 2-round Delphi to figure out what was essential versus just optional.
So they built on those first 2 rounds
Exactly.
to really refine those competencies even further.
Exactly, to tease out those nuances.
And it wasn't just them, right?
Yeah, it's a trend.
It's a trend. Klein and their team, who were focusing on teaching skills for clinician educators,
Right.
they used 2 rounds, and then they were even ready to do a third if they needed to.
Prepared.
Yeah, if they hadn't quite reached the level of agreement they were aiming for.
Yeah, makes sense.
And then Stenner and colleagues, who were updating those geriatrics competencies, they also did 3 rounds.
Yeah.
So you really see this pattern of going back to the experts multiple times.
Yeah, and I think it really highlights a decision point. For anyone who's planning a Delphi study, you have to think about how many rounds are you going to need
Right.
to get to a meaningful consensus.
Yeah, is it 2, 3?
It seems like 2 to 3 is kind of the standard we're seeing in these academic medicine articles.
Yeah.
But it might depend on how complex the topic is, how much disagreement there is initially.
Right.
And even Bacchus et al., who were working on those EPAs for shared decision-making, they also used 3 rounds
Yeah.
to get to that final list. And Skinner et al.,
Right.
after their initial work on geriatrics competencies, they did a national survey,
Interesting.
which you could almost consider like an additional iteration in a way.
Right. Yeah. It's like getting even broader feedback to further refine their initial finding.
Exactly.
Okay. So we've got these multiple rounds, and then something that is just so clear across all these papers is how critical it is to have a really carefully selected expert panel.
Yeah, the experts are the heart of the Delphi method, right?
Right.
It's not just random opinions you're gathering.
Right. These are people who really know their stuff.
Exactly. You need people with deep knowledge and experience in the area you're studying.
And it's not just any experts, right? You have to have the right experts for the question you're trying to answer.
It's all about alignment.
Yeah. And Rosticci et al., they did a really interesting thing. They actually had 2 panels.
Oh, wow.
So they had a panel of transition to residency experts, and then they had a separate stakeholder panel.
Interesting.
And that stakeholder panel included educators, residency program directors, and even residents.
Wow. So they had multiple perspectives.
Yeah, it was really cool. And I think it probably gave them a really comprehensive view of the challenges and the needs during that transition period.
Yeah, it makes sense. They wanted to capture the full picture.
Yeah, and lead it all, they were very specific about their expertise too.
Right.
So for that initial Delphi on AI competencies, they brought in professors, clinicians who are actually using AI in their practice,
Yeah.
software developers who are building the tools,
Right.
and then even industry experts.
Wow. So they had the whole spectrum covered.
Yeah, it was really impressive. And then when they wanted to refine those competencies and figure out which ones were truly essential versus optional, they brought in a different group.
Okay.
They focused on clinical professors who had experience developing curriculum.
That makes sense.
Yeah, because those are the people who are going to be actually translating those competencies into educational programs.
Exactly. They have that practical experience.
Yeah, and Klein et al., they also targeted their panel very specifically.
How so?
They only included individuals who were currently directing or had previously directed internal medicine clinician educator tracks.
Oh, wow.
So they were getting input from people who had firsthand experience
Yeah.
leading those programs.
But smart. They went right to the source.
Yeah, and then you see this emphasis on reaching out to the right people in other studies, too.
Yay.
Stenner et al., they really emphasize the importance of recruiting Canadian geriatrics experts through their professional networks. And then Baghus et al., they had a multidisciplinary panel, which is really interesting because they were looking at shared decision-making.
Right.
So they had experts in SDM, doctor-patient communication, and medical education.
So they recognize that expertise in shared decision-making can come from multiple fields.
Exactly. It's not just one discipline.
And even Skinner et al., with their geriatrics competencies, they had a broad panel that included clinicians, researchers, educators, and program leaders.
Yeah, it was really comprehensive.
So it seems like the takeaway here is you really need to think critically about who the right experts are for your particular question.
Absolutely. And then another thing that we see consistently across these studies is this idea of iterative feedback.
Right.
So it's not just sending out a survey, getting responses, and that's it.
No, it's a dynamic process.
Yeah, you're actually using the responses from one round to inform the next round.
Yeah, that feedback loop is key.
And Rustici et al., they were very explicit about that in their paper. They said that each subsequent questionnaire included a summary of the results from the previous round.
Oh, interesting.
So the panelists could actually see where the group as a whole stood on each of those skills.
And then they could kind of adjust their own thinking
Exactly.
based on what everyone else was saying.
Yeah, it's like a conversation.
Yeah, a structured one.
Right, a very structured conversation, but a conversation nonetheless.
And that's how you move towards a consensus, right? By considering everyone's perspectives.
And Lee Eleni, they did something similar.
Tell me about it.
In that second Delphi round, where they were trying to figure out what was essential versus optional,
Right.
the experts actually got to see the mean responses of the whole panel before they made their final judgments.
Oh, that's interesting.
Yeah, so they could see kind of where the group was leaning.
Yeah, and make a more informed decision about whether they agreed or disagreed.
Exactly.
So it's not just about your initial gut reaction, you're considering the collective wisdom of the group.
Now, when we talk about the Delphi method, we can't really skip over this idea of defining your consensus criteria up front.
Absolutely. You have to set the rules of the game before you start playing.
Right. You have to decide what level of agreement actually means consensus.
And that can vary depending on the research question and the field.
And Ristici et al., they set their threshold for inclusion at over 75% positive response.
Okay.
So that was their bar.
Their benchmark for saying, okay, this skill has reached consensus.
Exactly. And Lee et al., their initial open-ended round, didn't actually have a specific consensus criterion.
That makes sense because it was more about generating ideas at that stage.
Yeah, it was very exploratory. But then in that second Delphi, where they were looking at essential versus optional competencies, they did have a criterion.
Right, because they were trying to make more definitive judgments at that point.
Right.
So the way you define consensus can actually evolve as your study progresses.
And Klein et al., they were very specific. They required 80% agreement or greater
Okay.
on important or most important on their 4-point Likert scale. Wow, that's pretty high.
It is.
So they were aiming for strong agreement
Right.
on those core teaching skills.
Yeah, they really wanted to make sure that those skills were truly essential.
Makes sense.
And Stenner et al., they had a benchmark of at least 70% agreement,
Okay.
which on their 7-point Likert scale translated to a mean score of at least 4.9 out of 7.
So a little bit lower threshold than Klein et al.,
Yeah.
but still pretty high.
Yeah, still aiming for a good level of agreement.
And Baghus et al., they wanted at least a 6 on a 7-point scale.
Right.
And then in that final round, they upped it to 80% agreement.
Right on that near final list.
Right.
So they got even stricter as they went along.
It's like they were refining the consensus with each round.
And then Skinner et al., they defined agreement as a combination of somewhat agree and strongly agree
Okay.
on their 4-point scale.
Interesting.
Yeah, so they were looking for a certain proportion of those responses to indicate consensus.
So lots of different ways to define it.
Yeah, and I think the takeaway here is that there's no one size fits all.
Right. You really have to think carefully about what level of agreement is meaningful for your specific study.
Exactly.
Okay, so another common element we see is the use of Likert scales.
Yeah, the workhorse of the Delphi method.
Right, for collecting that quantitative data.
Right.
They're just so common in these Delphi studies.
Yeah, because they allow you to actually quantify those opinions and track how they change over time.
Right, and we saw some variation in the number of points on those scales.
Like what?
Klein et al. And Skinner et al., they used 4-point scales.
Okay.
While Stenner et al. And Begus et al., they used 7-point scales.
So a little more granularity there.
Yeah, and even the anchors of those scales varied.
What do you mean by anchors?
So like what the endpoints of the scale represent.
Oh, okay.
So in some cases, it was about the importance of a skill.
Right.
And in other cases, it was about the level of agreement with a statement.
So you have to be clear about what you're actually measuring.
Absolutely.
Yeah.
And it's not just about those numerical ratings, though. Many of these studies also incorporated qualitative data.
Yeah, they allowed for open-ended comments.
Right. And I think that's so important because it adds that richer context
Exactly.
to those quantitative scores.
Yeah, you can get a sense of the why behind the numbers.
In Stenner et al., they were very explicit about how they use those comments.
Tell me about it.
They said they used them to validate the competencies that they were proposing
Okay.
and to get suggestions for modifications or additions.
So they were really looking for feedback to improve their initial list.
Yeah, and Bagus et al., they did something similar.
Really?
They used the comments to refine the wording of their EPAs and the behavioral indicators.
So the qualitative data actually shape the final outcome.
Exactly. It's not just an afterthought.
No, it's integral to the process.
Okay, so we've talked about some of the common threads across these Delphi studies.
Yeah, those key ingredients.
Yeah, those key ingredients. But now I think it's really interesting to look at what makes each of these studies unique.
Yeah, where they diverge.
Yeah, because it really highlights how adaptable this method is.
Totally.
So right away, you see that the focus of each Delphi was very different.
Right.
Rusty et al., they were tackling that transition to residency.
Mm-hmm.
Lee et al. Were all about AI.
Yeah.
Klein et al., clinician educators.
Right.
And then Stenner and Skinner et al. Both addressed different facets of geriatrics competencies.
Yeah.
And then Bagus et al., they were focused on shared decision-making.
So quite a range.
Yeah, a huge range. And it just shows you how flexible this method is.
You can apply it to so many different areas of medical education.
And it wasn't just the topic that varied. Some of these studies also took some interesting twists on the traditional Delphi approach.
Like what?
So Ristich et al., they did what they called a modified Delphi.
Okay.
And they started with an expert panel brainstorming session and a literature review.
Interesting.
And then they sent out those surveys to the stakeholder panel.
So they did some groundwork before involving the broader group.
Yeah, they wanted to get those initial ideas flowing. And then they also did something else that was interesting.
What's that?
The responses from that initial expert panel were not anonymous.
Oh, wow. That's different.
Yeah, most Delphi rounds are anonymous,
Right.
but they decided to do it this way.
I wonder what the rationale was.
Yeah, it's interesting to think about. Maybe they felt like the open dialogue was more important in that initial phase.
Yeah, maybe.
But it does raise questions about potential bias.
True, if someone knows who said what, they might be more hesitant to disagree.
Right, especially if it's someone they respect or admire.
Yeah.
But Lee et al., they also took a slightly different approach.
Tell me about it.
They didn't just stick to experts. They
Yeah.
actually surveyed medical students and faculty members as well.
Wow, so they got a wider perspective.
Yeah, they wanted to get input from multiple stakeholders.
And they also used content validity ratio and interquartile range in their analysis.
Right.
Which are more quantitative ways of assessing the experts' opinions.
Yeah, they were really looking at the consistency and the stability of those ratings.
It's like they were adding another layer of rigor to their analysis.
And Klein et al., their focus was really narrow.
Oh, how so?
They were specifically looking at clinician educator tracks within internal medicine programs.
Right.
So they weren't trying to generalize to all clinician educators.
No, they were zeroing in on that specific group.
And Stenner et al., they were very upfront about using pairwise deletion.
Pairwise deletion, what's that?
So it's a way of handling incomplete responses in the data analysis.
Okay.
So if someone didn't answer all the questions, you don't just throw out their whole response.
Right.
You try to keep as much data as possible.
That makes sense.
And they also did something really helpful. They created a supplementary appendix with examples of each competency.
Oh, wow. So they gave people concrete illustrations of what those competencies look like in practice.
Exactly, which I think makes it a lot more useful for educators.
Yeah, it makes it more tangible.
Bagus et al., they emphasize their piloting process.
Oh, yeah. Piloting your questionnaire is so important.
Right, you got to make sure it's clear and understandable.
And they also translated their final outputs.
Oh, right,
Yeah.
which is important if you want your findings to be relevant internationally.
Yeah.
And then Skinner et al., they randomized the order of the domains and competencies in their survey.
Oh, that's smart.
Yeah, to avoid any order bias.
Yeah, because if you always present things in the same order, it might influence how people respond.
So they were really trying to be as rigorous as possible.
It sounds like it.
And the way these teams recruited their experts also varied.
Yeah.
Like Verstici et al., they use email lists from professional organizations.
Makes sense.
Lee et al., they relied on professional networking and snowball sampling.
Especially for AI, which is such a new and rapidly evolving field.
Yeah, word of mouth is probably really important in that field.
Yeah.
And Klein et al., they probably leveraged their own networks within the clinician educator community.
Right.
Stenner et al., they specifically targeted members of the Canadian Geriatrics Society and used their networks to reach that national panel.
And Bacchus et al. Likely tapped into those Dutch networks for shared decision-making.
So again, it's about finding the right people for your question.
Exactly, and thinking strategically about where those experts are.
And we talked about consensus thresholds earlier.
Right.
But I think it's worth mentioning again that while that 70% to 75% mark seems common,
Yeah.
it did vary a bit across these studies.
So there's some flexibility there.
Yeah, and I think it depends on the field. Like in a really rapidly evolving area, a lower threshold might be okay.
Right, because the field itself is still developing.
But in a more established area, you might need a higher threshold to really say, okay, this is a strong consensus.
Yeah.
And then how they dealt with those items that didn't reach consensus also varied.
Right.
Stenner et al., they were pretty decisive. They just dropped items that didn't reach consensus after 2 rounds.
Okay.
But other studies might keep those items in and maybe try to reword them or get more feedback.
So there are different strategies for dealing with those non-consensus items.
And then finally, the level of detail in those outcomes also varied.
Right.
Some studies ended up with those broad domains and competencies, and others like Bagus et al., they got really granular with those behavioral indicators for EPAs.
Yeah, so it depends on what you're trying to achieve.
Right. If you're trying to develop a curriculum or an assessment tool, you might need that granular detail.
Yeah.
But if you're trying to set the overall direction for a field, maybe those broader domains are sufficient.
So the level of detail should match the purpose of the study.
Okay, so each of these studies was unique in its own way.
Yeah.
But I think what's really exciting is to see the strengths that each one brought to the table.
Right. What did they contribute to the field?
Yeah, like Rostici,
Bishop.
yeah, they did a fantastic job of establishing that national consensus on transition to residency schools.
Right.
And they even provided entrustment guidance, which I think is so helpful.
Yeah, because it gives educators a framework for thinking about how to help residents develop those skills.
Exactly. And Lee et al., they were really breaking new ground with those AI competencies.
Right.
And the fact that they included students, faculty, and experts gives their findings a lot of weight.
Yeah, it makes it more credible.
And Klein et al., they really addressed a specific need with those teaching skills for internal medicine clinician educators.
Yeah, those tracks are becoming more and more common.
Right.
So it's really important to have clear guidance on what those residents should be learning.
And Stenner et al., they did a great job of updating those geriatrics competencies using those current frameworks.
Right, like the 5Ms and Canadar.
And the fact that they had a national panel really enhances the credibility of those findings.
Yeah, it makes it more applicable across Canada.
And Bagus had all those EPAs and behavioral indicators for shared decision-making.
That's huge.
It is.
Because it gives programs a roadmap for teaching and assessing SDM.
Exactly. It makes it a lot more concrete.
And Skinner et al., they really focus on those medical student competencies for geriatrics, which is so important because that's where it all begins, right?
Right. We need to be preparing students for this from the very start.
And they use that national survey to make sure that the competencies were relevant
Right.
and achievable at the undergraduate level.
So really impressive work all around.
Yeah, very inspiring.
Now, for anyone listening who might be thinking about doing their own Delphi study,
Yeah.
and especially if you're hoping to publish in a journal like Academic Medicine,
Right.
what are some of the key takeaways from these examples?
Yeah, what should people be keeping in mind?
So first and foremost, you need a really clear purpose and rationale.
Absolutely.
Like, why is this study important?
Right. What gap in knowledge are you addressing?
All of these published articles, they did a great job of articulating that need right up front.
Yeah, they made a compelling case for why this consensus was needed.
And then the methodology has to be really rigorous.
Yeah, you have to be transparent about every step of the process.
So describe the specific Delphi method you used, any modifications you made.
Right.
Explain how you selected your panel.
And your inclusion and exclusion criteria.
How many rounds you did.
And why.
How you developed your survey instrument.
Like, did you do a literature review?
Did you pilot test it?
Did you get expert input on the design?
Yeah, all those details matter.
And then, of course, that a priori definition of consensus.
Right.
How did you decide what level of agreement was sufficient?
And you need to describe your data analysis methods.
For both the quantitative and qualitative data.
And don't forget to acknowledge any limitations.
Right.
Like potential biases.
Or issues with response rates.
Now, speaking of the expert panel.
Yeah.
The composition of that panel and the response rates you get are going to be really important.
Right.
So aim for a geographically diverse and representative group.
Yeah.
And describe your recruitment strategies in detail.
And report those response rates for each round.
And talk about any implications of declining response rates,
right,
if that's something you encountered.
And when it comes to reporting, your findings be transparent.
Absolutely.
You can't just say you reached consensus. You have to show the evidence.
Right. So present the results from each round.
Yeah.
Show which items reached consensus, which ones didn't.
And consider using supplemental appendices for the full survey and the detailed results.
And don't stop at just listing those consensus items.
Right.
You need a discussion section that really explores the implications. So how can these findings be used?
Right. How can they inform practice?
Curriculum development assessment policy.
And what about future research?
Yeah, what new questions have emerged?
What directions should we be exploring?
And then, of course, always remember those ethical considerations.
Right. IRB approval if needed.
Okay, so to wrap it all up,
yeah,
the Delphi method is a really valuable tool
it is
for building consensus in medical education.
And we've seen how it's used in academic medicine.
Yeah, multiple rounds of surveys,
expert panels,
iterative feedback,
clear consensus criteria.
But we've also seen how adaptable this method is.
Right. Each study had its own unique twists.
So think about your research question.
Your methodology.
Your panel. Your consensus criteria.
Your reporting.
And for anyone aiming for academic medicine.
Yeah.
Remember those key elements.
Purpose rationale methodology.
Panel response rates.
Transparent reporting.
Discussion of implications.
Ethical considerations.
And as we think about the future of medical education,
yeah,
and the need for consensus in these rapidly evolving areas.
Like AI?
Interprofessional education.
New models of care.
How do we see the Delphi method evolving?
Yeah.
What new approaches can we use to engage experts?
To measure consensus.
To really maximize the impact of this methodology?
It's a fascinating question.
It is.
And one that's worth pondering.
Yeah, thanks for joining us for this deep dive into the Delphi method.
It's been a pleasure.
And we'll see you next time.
See you then.